Okay. Good evening, everyone, and welcome. I'm Jenny Tassler of the Associated Medical Schools, and welcome back to the AMSNY Diversity in Medicine series. Tonight, we are focusing on rheumatology. But before we get started, I wanted to do a few housekeeping notes. Due to the size of the webinar, we've put everyone on mute to start. We will have time for participants to ask questions, and we do encourage you to ask questions. Please feel free to drop a question in the chat, or when we have a time, raise your hand and we'll give you the ability to unmute and ask your question. So let's get started with a brief introduction of our speakers. I'll let them do a more in-depth intro later. Our speakers tonight are Dr. Irene Blanco and Dr. Alisha Akinsete. Dr. Blanco is a professor of medicine at Albert Einstein College of Medicine, where she specializes in adult rheumatology and is also the Associate Dean for the Office of Diversity Enhancement. Dr. Akinsete is currently finishing her fellowship in pediatric rheumatology at the Children's Hospital at Montefiore Einstein and is heading to her first job soon. I'll let her tell you a little bit more about that. So I thought I'd start out with a little bit of level setting just to get started, since we have a variety of educational spectrum here tonight. Dr. Blanco, can you tell us a little bit about rheumatology? What are the diseases you treat and what do you do?
Sure. So the easiest way to think about rheumatology is that we really do a lot of autoimmune and autoinflammatory disorders. So what does that mean? It means that we take care of a lot of the diseases where your body's immune system just runs amok and starts pretty much attacking itself. There are a whole host of autoimmune diseases that really affect every single organ system. We don't take care of all of them, but we take care of most of them, right? So for example, you may have heard of like Crohn's or ulcerative colitis. Those really affect like the intestines, the stomach, the bowel, et cetera. Gastroenterology really does the bulk of that work, but we will partner with them when the patients have, disease manifestations outside of the belly. There is Hashimoto's, which is autoimmune attack of the thyroid, really, really common in young women. And a lot of our patients will have that. That's typically in the wheelhouse of endocrinology. And again, we do all of pretty much the other ones. So we take care of lupus, rheumatoid arthritis, Sjogren's, scleroderma, you name it. I'm sure a lot of you have heard, like, ask your doctor about Humira, ask your doctor about Enbrel. Those are ours. And so I'm on the adult side, and Dr. Akinsete is on the ped side. And what's really notable about our diseases is that they're multisystemic. So in fact, they attack pretty much every single organ system. And so we're trying to manage literally everything all at once. And because it's the immune system, it's incredibly complicated. It's incredibly sort of like ethereal. Nobody seemingly understands it except us sometimes. But it makes that we get to work with like a lot of different specialties and help to coordinate the care across disciplines. But at the same time, our diseases, unfortunately, even though they're not curable, they're treatable, but then that allows us to have really long-term relationships with our patients. So we can be our patients' doctors for, 10, 20, 30 years, depending on whether we're on the peds or adult side of the house. And so, I like to say it's like the best of primary care combined with specialty medicine.
Great, thank you. So Dr. Akinsete, is there anything specific about pediatric rheumatology besides just the age of the patients?
So actually, a lot of our diseases that are similar in adults affect children, but specifically in a more, they have like higher, their disease is more severe. So with lupus, there are more mild forms, but you kind of see them more in adults, and as opposed to in pediatrics, where they're really affecting the kidneys, can affect the cardiovascular system. So a lot of our diseases are very similar to the adults, but they can manifest in more severe ways. So I think that's really important that we are, as rheumatologists, I think that's something else that like we are always on the cutting edge. There's always some new medication that is coming out, and there's a lot to still learn. So I think if you're interested in research, that this is a great opportunity, because there's also multiple different, it's basic science, clinical. You can do a lot in rheumatology, because still there's a lot of unknowns. Recently in 2020, like we started using JAK inhibitors in pediatrics, but on the adult side, a lot is approved a little bit faster. In 2019, Benlysta. So, there's a lot of opportunity to really help our patients in a really significant way. So I just wanted to put that plug in.
So continuing with Dr. Akinsete, what drew you to both medicine and then to rheumatology?
So for me, what drew me to medicine was my own personal story. I was diagnosed with lupus when I was 12. And I really had a lot of, they called me mixed connective tissue, because I had a lot of arthritis, but didn't have specifically like rheumatoid factor or like specific antibodies, and I didn't really have damage. But then later on, I got diagnosed with lupus nephritis, and had very bad disease, and I ended up needing a kidney transplant. So really, being a patient in the health system really, besides wanting to cure lupus and help everyone, I could see, like I held different support groups. I actually ran support groups from the Lupus Foundation and saw significant disparities in care, as opposed to like this white patient with lupus. And, and these are all, patients that are part of this support group, as opposed to the Black nurse that had lupus. So I felt that, but I also saw it more broadly and widely as a student. And then throughout my medical training, I saw it more and more. And it really, that's kind of what drove me to really address healthcare disparities in pediatric rheumatology, because a lot of our disease, like I mentioned, like lupus and dermatomyositis, JAA, severely affects Black and Hispanic and Indigenous patients more so than white patients. So that's really important for me to solve and fix. So that's really what drew me into pediatric rheumatology. And as Dr. Blanco mentioned, it's really multi-system. So for a second, I even thought about emergency medicine, even though it's completely different, but it's still that same concept of you're really looking at the whole body from head to toe. You're looking at MRIs, you're really looking at the ophthalmology notes, you're looking at the echoes, the pulmonary function tests, like you're doing all of these different things and are involved, with all of these discussions with all the providers. So I just think that coordinating all of that, being involved with all that is just very exciting.
Great, thank you. And Dr. Blanco, what was your path to both medicine and rheumatology?
Medicine. So I was a little bit of a jack of all trades. So for those of you that are in college, I'll just tell you now, you do not need to be a science undergrad. They told me, in back in my day, and yes, I'm dating myself because I am old. They handed us a paperback like course catalog, and so I flipped open to pre-med. That like first semester, first year, freshman year. And I look at the requirements and they're like, you don't need to be a science major. I'm like, done. I'm not going to be a science major. Because I thought, well, I want to be a doctor, so I'm going to be doing science for forever. Like I want to do something random and different and fun. So I was a French major. And I will go to my death arguing that we need more humanities because it's going to teach you to better critically think and defend your opinions, like when you go into medicine. But that's a discussion for a separate day. And so, I was just kind of really interested in a lot of like big ideas and really big thoughts. And like, that's really what attracted me to medicine, just science and research and like helping people broadly. So I didn't really know if I wanted to do science. I toyed with the idea of doing MD PhD because I had done a lot of bench research, but I also really wanted to do my MPH because I was interested in like thinking about problems more systematically. And then as I was going through medical school, like the idea of rheumatology just came up. I love immunology, and really the basis of rheumatology is that your whole immune system is incredibly deranged, right? From kit to caboodle, like every single part of it is messed up. And then subsequently it causes all of these horrible cascades of inflammation in patients, right? So that scientifically I found incredibly interesting, but like in all sincerity, it was the patients, right? Like the patients like Alisha, because I'm going through medical school, I'm in my 20s and 30s, I'm meeting so many patients that are in their 20s and 30s, right? Like I'm Latina, I'm in medical school in the Bronx, I went to Einstein, I'm still there. And so it was just like these are my patients, like this is part of my community, right? So it was this idea of like I could help my community and really address a lot of the disparities that we see in rheumatologic care, because there's not a lot of rheumatologists. Our medicines are way too expensive. Access on all levels is problematic. But at the same time, I could do a specialty that I found incredibly interesting scientifically, that like always has you asking questions. So like I tell my learners and my trainees, like rheum makes your brain hurt in all the right ways, right? Because it's like you're like, oh, what's happening? And like, the heart's not working, and then that makes the kidneys not work, and then with the kidneys not working, you're like, this is not working, and you're like, how do I fix this but also fix that? And it's just so complicated. But at the same time, like, you have a patient and oftentimes they're young, they're like just starting their careers, they're just starting their families. So it feels like so high stakes, right? Like I really need to do right by this person because, if this person becomes chronically disabled because of this disease, like that's going to impact generations. Like what does that do to the earning potential of that family, right? What does that do for the rest, like for their place within a community? And again, it's sort of like those big picture ideas and systems that really attracted me to Rheum.
Great. Well, I think this is a good spot. Somebody posed a question in the chat. It says, speaking of the longitudinal relationships rooms build with their patients, would you say that rheumatologists end up being the unofficial PCP for their patients? Or relatedly, how do you manage the sharing of a patient with the primary care physician? And I guess in the pediatrician world as well. So they may have multiple for both of you. I mean, it may be different for adults and peds too.
Well, I think it's important to say that like, to be a pediatric rheumatologist or to be an adult rheumatologist, first you're trained in the baseline specialty, and then you go on to do extra training in rheumatology. So like I am an adult physician. I can practice adult primary care if I want to, but I did extra years of training to be a pediatrician, to be a rheumatologist, not a pediatrician. I'm looking at Dr. Akinsete when I said that. No, I'd be the world's worst pediatrician, honestly. But then you do extra years. So like we end up becoming primary care because we're trained in that specialty, right? And I think at least on the adult side, we're doing so much of the coordination, and there's so much different organ involvement and whatnot that I think the PCPs sometimes are a little overwhelmed. And so it's not that they're not important, they'll be incredibly important, but oftentimes we're kind of taking over and they see us a lot more than their general primary care physician. But Dr. Akinsete.
Yeah, no, I agree with all of that. And in particular, a lot of our patients, you know, like things that you think of, like that you see your PCP for, like vaccinations. That's super important for us. You know, like they need to be vaccinated because we're giving them immunosuppressive agents. So sometimes they actually end up needing additional vaccinations on top of that. Like we're also talking about reproductive health. A lot of our medications are can cause issues to a growing, you know, baby. So we make sure we send them to adolescent and we have these conversations. You know, specifically, I mean, overall, I think so, you know, that being diagnosed with a chronic disease is very debilitating, but also mentally it is very debilitating. So we're also doing PHQ-9 screens, like screening for depression, screening for anxiety. And like Dr. Blanco said, we see them more often. We see them even for like a well visit. We see them every 3 to 6 months just to make sure that everything is still going well. So, you know, for a regular like a pediatric visit, you see them annually for your regular visit, like a regular physical. So we're seeing them a lot more frequently, and we're handling a lot of those things that the regular PCP would do. I mean, some of the things like development, even those things like forgetfulness, like for lupus, it could affect the brain. We're also asking a lot of these questions and sending them to a, you know, for neuropsychiatric evaluation. So there's a lot of ways that our diseases can affect certain things that the PCP would screen for already, like, you know, diet, nutrition, all of that's really important. And, you know, as a rheumatologist, we're really taking care of all of those things. So, I mean, I think that there's still a function for the regular pediatrician for other things. But we're really their home. we're their
Yeah.
home.
And on the adult side, for example, like the PCP typically, unless the patient is being followed by family medicine, the PCP is not involved during a patient's pregnancy, whereas the adult rheumatologist actually gets closer to the patient probably during their pregnancy, because a lot of our diseases can get exacerbated by pregnancy, or pregnancy complicates the disease, or our diseases predisposes them to a complicated pregnancy. So I feel like, you know, we do the gamut of reproductive health, like because our patients can have children and can have very healthy and successful pregnancies, but oftentimes they have to be planned pregnancies for that to happen, right? So it's, if an unplanned pregnancy happens and their disease is exacerbated, we're on deck, right? And we're trying to manage them through that. Or if their disease was quiet when they got pregnant, but then it became active, right? How do we help protect, you know, mom and baby to get to a really, you know, healthy delivery and healthy baby? So if anything, you know, we do a lot of GYN, we do a lot of reproductive health, but not only for, you know, like people that get pregnant, but like everybody that's trying to get those people pregnant too. So it's, you know, we really run the gamut in sort of like life milestones with patients. And it's amazing because, you know, I typically say like rheumatology patients can get really sick really fast. So like they kind of walk along a cliff, and like our job is to be there walking along with them, that when they get a little too close, we yank them back. Right. I feel like that's our perpetual role, because they can get so sick so quickly. But we, you know, walk along with them.
Great. So one of the things that we've talked about beforehand is that rheumatology is undersubscribed. It's, you know, there is a shortage of rheumatologists across the country, particularly in pediatrics. How do you address that? How are, you know, besides conducting this webinar and trying to expose students, what are some of the opportunities for people who might be interested in pursuing rheumatology, or getting people interested in this specialty?
In particular, I mean, we're working, this has been like a big discussion with both the American College of Rheumatology and also on the research end of the Childhood Arthritis Rheumatology like Alliance for CARA, because particularly in pediatrics, the world, you know, in the United States of America, there are around 300 pediatric rheumatologists. There are many states that have 0 pediatric rheumatologists. Patients have to drive hours upon hours to go see a rheumatologist. You know, like I think patients are lucky here in the Northeast because it's a little bit, you know, it's more saturated in this area, but everywhere else it's an issue and a problem. So things that, and we talk about diversity of the pediatric rheumatologists, it's even worse. There's, I think it's like 3% Black pediatric rheumatologists, and even less so for Hispanic, and even less for Indigenous. So ways that we discussed and things that we're looking at besides doing these webinars is also like doing things like working with pathway programs in particular, and even just having a deck of PowerPoint slides that we can go ahead and show to other institutions. But other things like visiting professorships, I know that's something that we are also working with. But to just get involved, we've been working also in increasing in American College of Rheumatology access to come to the meetings. And I think that that's a great opportunity to meet a whole bunch of rheumatologists. And they really focus on the trainee themselves. Like, so they have like specific trainee sessions. So SOTA, I think it was great for them because they had specific sessions about like, what is rheumatology? What is lupus? What is dermatomyositis? So they provide these scholarships for them to come in person or virtual. So I think, you know, that there are plenty of opportunities to get involved in that sense. And hopefully with that involvement, you guys become interested in becoming rheumatologists. But yeah, Dr. Blanco always knows all the resources.
So, well, like full disclosure, Dr. Akinsete and I sit I co-chair the task force, and she's one of my task force members. So we're in the thick of it with the American College of Rheumatology. So we actually have 2 pathway programs right now for medical students, but hopefully it's going to be expanded to college students in 2023. So so right now through the Rheumatology Research Foundation, you can apply for a scholarship. This is actually for college students, medical students, or residents to go to our national meeting. And when you come to our national meeting, they'll pay for airfare, transportation, hotel, you name it. And then when you come, you actually get invited to hang out in all of the trainee sessions, right? So it's like life as a trainee, you get to meet a lot of the fellows, and then start to network early. And through the American College of Rheumatology, it's actually medical student specific. But then hopefully, knock on wood, this goes live, fingers crossed, 2024, that we'll have for college students opportunities to do research fellowships during the summer in labs that are doing rheumatology research, with the idea that you get to do some research in the lab and then subsequently present your research at the national meeting. So you get a research mentor, you get a research experience, and then eventually you can come to the meeting and network with everybody else in the program. So fingers crossed, that'll be 2024. But you can look at the American College of Rheumatology. It's at rheumatology.org. is going to be our first scholarship for the national meeting. So for those of you that are medical students, our national conference this year is in Philadelphia, so not too far away. And it promises to be an absolutely great meeting. And the application should go live sometime in July.
Wonderful. And we'll usually follow up. We'll put those in the
Awesome.
comments on the recording as well. I'm going to pause for a second because I see a hand raised. And if you have a question, be sure to raise your hand or just drop it in the chat. If you're not in a place, you can ask it. So Teresa. On you?
It's Teresa.
Teresa.
Hi. Hi. I have a question. So I was wondering about endometriosis and IBS. Are those type of treatments that rheumatology doctors treat?
So endometriosis would definitely be more OBGYN, and IBS is more gastroenterology.
Okay. So you would treat something like, what is it? Rheumatoid arthritis or something?
Rheumatoid arthritis. Yeah,
Yeah.
exactly.
My
That's
dad had that illness. He was in a lot of pain.
definitely. And the thing is, like, you think of rheumatology, you think of joints, but the only reason, like, really the joints love to get involved in everything, right? Like, you catch a cold and all your joints hurt, right? Like, you get a fever, everything freaking hurts. And it's mostly because, like, the blood vessels in the joints are very, very open, right? So all the junk that's floating through your body gets into your joints. And it's very easy to get joint inflammation, like whenever something else is happening in your body. But really, our diseases aren't only joints. Like, you'll see, for example, lupus, yes, they get a lot of arthritis, but they get kidney issues, they get skin issues, they get lung issues, they get other organ issues. So a lot of times people think joints, and yes, joints and what we call the musculoskeletal system is involved, but it's usually like joints and, right? It's very, very rare that it's just like only the joints. Like, usually there's at least one other organ that's making mischief somewhere.
Any other questions?
I was just wondering also, couldn't they confuse that IBS and you really have some type of arthritis, or if it's definitely in your stomach, then it's definitely IBS?
Well, that's where, like, a gastroenterologist can kind of help you figure out if it's IBS or something a little bit more serious. And then if we have to get involved, then they send the patients over to us.
Okay. Thank you.
Sure.
Sort of piggybacking off of that question in terms of the interrelationship between specialists. And, I know that we've talked in the past about how many physicians somebody has seen before they get to you, before they're diagnosed with a rheumatologic disease. How does that factor into your ability to care for them, how they come to you? Maybe you can talk a little bit about the patients you see.
So typically, before, if they have more mild disease, they've probably seen, and they have arthritis, they've probably seen an orthopedist. If they have skin disease, they've probably seen a dermatologist besides their regular PCP. It might have been diagnosed with eczema and it's something else. So usually it's hard to make these diagnoses. And even for something like mild scleroderma, to notice skin tightening of the hands is like very difficult, or just swelling of it. They can just say, oh, it was the heat. So there's very, like, our physical exam findings are very specific. And if you aren't aware of them, it's very easy for a patient to go years before seeing us. So a lot of the times they come and they're usually in the hospital or very bad, needing a lot of systemic steroids and a lot of medications in the beginning. So they really come, and I think another part of this too, besides really working in the outpatient world, if you're in academic medicine, there's a lot of inpatient work as well. So it's almost, like, you get also the best of both worlds, inpatient and outpatient, in regards to seeing a lot of new diagnoses. And like Dr. Blanco said, patients that have flared, like they're walking on this cliff, we see them a lot in the hospital. So they see a lot of other physicians before seeing us typically. And when they finally do, they're in the hospital swollen, not being able to walk, because their kidneys have been affected, their joints are affected. And that's typically either there or they've seen a couple of other providers.
But just to piggyback off of that, like, very few, like, overall, our diseases are pretty rare.
Mm-hmm.
Now, that being said, they disproportionately affect Black and Brown patients, right? And so we practice in the Bronx. So, like, rare diseases are not so rare anymore when you're in the population that is most affected, right? The problem is that it's a small specialty, And our training programs, right, focus on teaching everybody the more common things and how to recognize the more common things. So, cardiology and the main lung issues, like for on the adult side, like emphysema and COPD and smoking and heart disease, yada, yada, yada. So, very few medical schools have a rheumatology course, period, like at all, right? So most medical students will go through all of medical school hearing obscenely little or even meeting a rheumatologist, period, right? Then they go into residency and they do their residency. And unless they decide on their own to take a rheum elective, they probably will never rotate through rheumatology. And maybe they'll get like 1 or 2 patients on their service, but that's it. So now they become independent practicing doctors and they've never seen our diseases before. So our patients show up and they don't know how to interpret findings. They don't know what the hell they're looking at. So oftentimes our patients go either underdiagnosed or misdiagnosed for years. And they end up, as Dr. Akinsete said, like in the hospital because somebody kept looking at their urine and misinterpreting like their urine values as inflammation or as like an infection. Oh, you have a UTI, you have a UTI, you have a UTI, right? And keep getting rounds and rounds of antibiotics when in reality, the fevers, the joint aches, the pains, etc., is that they're in progressive kidney failure from their lupus kidney disease, right? And then we find them when they're on the verge of dialysis. Right. But if you go back, you see that for the past year, they've really been having symptoms, just no one put it together because doctors on average are not trained to see these patients. So we actually have a program that we developed through the ACR where fellows actually go out and teach primary care providers how to diagnose lupus and how to recognize lupus early. Because again, when a woman's like 18 years old and has to go to a kidney transplant, like hopefully everything goes okay and hopefully she finds that organ. But if she doesn't, what does that do to the rest of her life, right? Like going to school, having a family, etc.
Great. Gordon, you should be able to unmute.
Hi, good evening. Thank you so much for this. My question is about care teams. One of the things that you both described is that a lot of doctors are involved in patient care and may not be aware of what to do. And I come from public health, and so like there's a lot of potential gaps. And also like in the harm reduction field, if there's like a one-stop shop that can improve a lot of healthcare opportunities, but being that there's such a small population of rheumatologists in the US, what innovations can the rheumatology field do? Like, especially with COVID, that's been something that for a lot of disabled populations, it's been difficult to do, but like, are there like remote and like maybe like, I guess like centers that can help with like the diagnosis and getting people connected to a rheumatologist across the country? Or just what do care teams look like now or moving forward?
Yes. Like, yes. So Dr. Akinsete knows this, but one of our colleagues, Liz Ferrucci, who is actually works with the Indian Health Service in Alaska. And so she provides rheumatologic care for an enormous catchment population. Like people don't realize that Alaska is pretty much a size of like the 1/3 of the continental United States. It's flipping enormous. And so she's been doing telehealth for well over a decade, right? Where she would like once every few months fly out to really remote communities in the Yukon, but for example, would have like a community health worker there trained to find disease manifestations, do a musculoskeletal exam, know what to order in terms of testing, et cetera, for the medications. And then Liz could, do a lot of things either through iPhones right? Through Skype back in the day before everybody had Zoom, and eventually through WhatsApp, right? Like, I mean, now everybody has Zoom, but back in the day, it was like, you know, like sketchy little video calls through Skype and WhatsApp, right? Anybody that's international here knows that. So, you know, there are efforts. The ACR established something very similar in Georgia, where there's very large centers in Atlanta, but giving a lot of telehealth support to rural communities in Georgia. You know, I think little by little, we're working through more of those models, but there are places that are establishing room centers of excellence, whether it's disease specific. So for example, Montefiore, where we are, has like a lupus center, but other healthcare systems have different ways of doing that. But it's kind of like having everybody come together to coordinate the care, because everybody needs to talk to each other, right? Because you don't want, for example, me to try to fix one thing and you to try to fix another. But when I try to fix my thing, I end up breaking your thing, right? Because it's not going to help the patient in any way, shape, or form. So if we're not dialoguing together, it's the patient that suffers.
I agree with all of that. And even now, they're working on studies to see how, since COVID happened, particularly with the pediatric patients, looking at studies on how we can best do physical exam. Because even here at Montefiore, we see patients all the way in Orange County. So sometimes we just do things, you know, we'll see them in the office, get labs, but we do televisits also with them, just to make sure that we're keeping like continuity of care and seeing them regularly. So even in the Bronx, we're doing telemedicine for our patients. So I just think it's us trying to figure out ways that we can make and take advantage and make the most of the telemedicine visits, because even doing labs by them, seeing them via telehealth, that's an effective way, you know, could be an effective way of seeing them more regularly. But yeah, I think we're making strides.
There's a question in the chat about early detection of rheumatologic diseases. Are there any promising advancements in technology to detect rheumatological diseases so patients don't have to see so many doctors before reaching a specialist and to receive treatment? Do you see any pathways of that sort of development, or is it more just the education that will help physicians identify that in their patients?
Yeah, it's really more the education, because even for us, we come up with new ways to diagnose lupus every couple of years, coming out with some new criteria. We had the ACR 1997, we had the SLIC, now we have the Euro-lupus. So even for us, things are changing. So it's really more of education and really figuring out specific findings, like, if we see a big glaring butterfly rash that's raised and, they're having fevers and joint pain, that, hey, I should think about, lupus. So I think that, just very giving education. And we are doing that here, particularly at Montefiore, in pediatric rheumatology, we are going out into the community and doing these presentations to the general pediatricians around here and in Westchester, and even in Orange County. So that's really the best way.
But I think it's going to take a lot of just advocacy on the ACR's part to really start thinking about how this has to be better integrated in a medical school curricula, right? You can't keep ignoring this, because the musculoskeletal exam is the one that's often least taught, right? And there's national data about this, that medical students often come out of medical school with the least amount of skills in their musculoskeletal exam, right? So they don't know how to do the exam and they never saw the diseases, right? And then they go to residency, where oftentimes a lot of the joint pains and aches goes to either orthopedics or rehab, right? So then none of those skills are then reinforced there, right? So it's then we expect them to be fellows and to know all this stuff, when in reality, they've had very, very, very little foundation, right? But if you're a PCP in the community, you know, like we had the chance to like find Alisha, right? And regardless of her personal history, and then have her become a rheumatologist, but most people will not become rheumatologists. The situation isn't as dire on the adult side, but it's still pretty bad. Like we need about 8,000 rheumatologists to adequately, not well, adequately serve the US population. And we have about 5,000, right? So we're missing 3,000 rheumatologists. That's why we do this, right? Because you're not going to hear about it through medical school. You're not going to hear about it through residency. So we literally have to like bang the drum and go knocking on doors and saying, hey, one of your rheumatologists. Because otherwise, when the hell are you going to hear about it? Seriously, like unless you have the disease or you know somebody that has the disease, the likelihood that you're going to get exposed is very, very low.
Great. I'm going to let Lakeisha, you had your hand raised.
Yeah, hello, can you hear me?
Yes.
Oh, thank you so much for this. Those were some very alarming facts, Dr. Blanco. 3,000 short, geesh. I just want to ask you both, how do you guys feel about gene editing, using CRISPR as a form of a way to possibly treat rheumatoid arthritis? Because like you said, you don't know about rheumatological diseases unless someone you know has one, or if you have one yourself. And I wasn't discovered to this field until my mother was diagnosed with rheumatoid arthritis, and that just fueled all my studying in undergrad. And then in my master's, my thesis is about gene editing using CRISPR in order to form a way to treat it. Because what it looks like now, like, because I worked in a rheumatology private practice for 3 years, and one of the main issues was I love the patients. It was, we were treating the pain, but the interleukins were still rising, or we were able to get that under control, but we weren't really do much about the pain. You know, you throw in insurance and they're all talking about, you know, you only get this every 3 months, we're only going to pay for it. You know what I mean? So how do you guys feel about gene editing?
I mean, on the pediatric side, a lot of our diseases, I mean, I would say maybe the autoinflammatory diseases have more specific, like you can target a specific gene. I mean, this hasn't even been studied. So, you know, like I can just put that out there now, at least on the pediatric side. But a lot of our diseases have multiple genes that are involved. Like with lupus, it's not just one gene that you can go in and it's like 20 genes that it would have to be affected, and all of them are different in different patients. Because, you know, like lupus is not, like lupus is on a spectrum. Not everybody looks the same, so that, you know, like it can be explained with their different genes. And same with like rheumatoid arthritis and all these other diseases. So, you know, I think a lot of studies are still happening now where they're even trying to figure out what genes are involved. But I think we're very far off on that. But we are looking at specifically trying to target like cytokine profiles and looking at genes to target what is exactly happening, whether it's you know, their adaptive immune system, so their B and T cells are what's wrong, or, you know, if it's their innate immune system, like, or if it's more an interferon response, like, so we can target the medications a little bit more, and that is more coming in the future. But in specifically like targeting a specific gene, I think we're a little far off from that. I mean, maybe in the adult world, I don't know, Dr. Blanco, but
no, yeah,
not on our side.
But like you hear it, right? I mean, it's like you know, we're doing a lot of primary care, and yet at the same time, we're talking about like all of this basic science. Like you will sit there in clinic and you're like, you know, and you'll get either like, you're really confused. So you get a cytokine profile and you're like, their IL-6 is elevated, so let me try this med as opposed to this med, where, you know, we're really going, it's not infrequent that we're going down to the cellular level in how we treat our patients, which is kind of bananas. Like a lot of doctors don't think that way, right? Like, you know, high blood pressure, you give a medicine, this, you give that medicine, whatever. Like we're really sitting there thinking, all right, let me think of this antibody profile, or what did I find on biopsy? And oh, the biopsies were more T cells. So let me pick a T cell directed medicine as opposed to like a B cell directed medicine. Like we're really thinking about the patient on a on such a holistic level, right? Like from down to the cells all the way to their social determinants of health, right? Because that medicine that I want to give them costs $125,000 a year. So how the hell am I going to do that if they're Medicaid living in a shelter, right? And a lot of our medicines, like you've heard, there's all these patients that subsequently had COVID, despite the fact that they were vaccinated and boosted. Like those were our patients. So if you, like Gordon, if you want to talk about risk reduction, like all of our patients, like we bang the vaccination drum all damn day. Like my patients are sick of me at this point. And I keep telling them that I just want to send them out into the world wrapped in Lysol wipes, because, I have nobody around them is wearing masks, right? So we have patients that in essence have become homebound because they're terrified of going outside because we've prematurely released these mask mandates, and they're on medicines that are keeping them alive, but that put them at such great risk for dying from COVID, despite the fact that they're vaccinated and boosted, right? And our vaccination series is not just 2 vaccines and then the booster. It's 3 vaccines baseline, then the booster, then the second booster. So we're at like 5 shots for our patients, and they're still not protected enough because of the way our medicines need to lower their immune system so that their immune system doesn't kill them. But then they, become at risk for other things.
Teresa, I see your hand back up.
Yes. Yes. Can you hear me?
Yes, we can.
Oh, okay. I have a question about COPD. So which type of doctor, is it a cardiologist or a pulmonary doctor that does the treating for the COPD, or is it family practice? I was just looking on the internet because my mama has COPD. When I was shadowing the cardiologist, I came across a lot of patients who did have COPD, and then he was like, well, if they're diagnosed with this, there's nothing else we can do. Is that still true? What are they doing about this COPD? Because I didn't like that the patients that I was seeing, when I asked about them the next day or so, they were gone.
So COPD is predominantly a lung doctor.
Okay.
That's a pulmonologist.
Okay. So is this still, do you know, still untreatable?
I mean, there's medicines for COPD, but that's not in my wheelhouse.
Okay. Thank you.
Sure.
Kelly, I think you should be able to unmute.
Yes, thank you. Good evening, everyone. Thank you so much for all the information. I also love immunology, so this sounds especially interesting. But given all the barriers to diagnosis, I was wondering, are the majority of the patients that you diagnose, I guess predominantly for the adult world, are the majority of them in a flare, or are you able to diagnose them when they're not flaring or critically ill?
Well, they typically don't come to me until they have symptoms, right? So, because otherwise I'd never know about them, right? Because if you don't feel anything, well, then I'd never know. So typically, when I first meet them, they're in some sort of a flare, whether they're sick enough to be in the hospital or they can make it to me as an outpatient, really depends on their disease and the nature of the flare. But for the most part, we find patients when they already have some disease manifestations.
Okay. We also had a question in the chat about, in terms of the musculoskeletal training, do you find differences between MD and DO students, since the training is a little bit different?
Oh, yes.
Oh,
yes. Yes. The DO schools actually teach you how to do a musculoskeletal exam. I love DOs. I love DOs. As a training program director, like one of my fellows that's coming in is a DO. And I'm like, oh, she's gonna know how to like do an exam. I'm so excited. I don't have to start de novo and be like, so this is a wrist, right? Because honestly,
And
like, I mean, I will see some residents doing a musculoskeletal exam like this, and you're like, sweetie, you did not pay that much money to do this kind of exam. What are you doing? Like, I mean, that's how deranged the musculoskeletal exam education is, I think, in allopathic medical schools. If you go into PM&R, if you go into ortho, you're self-selected, right? And you probably do a whole bunch of electives that teach you how to do the exam. But generally, you know, they get one session, they get 2 sessions, they never use it again, right? And then it's not until their further training, as opposed to DO, because the osteopathic maneuvers is so critical to their curriculum. On average, yes, they do a much, much more thorough MSK exam. And I love having them as trainers. Like, I love you.
All right. Shout out to all the osteopaths out there. Lens, you should be able to unmute.
Can you hear me?
We
Yeah.
can.
Okay, awesome. Well, thank you for taking my question. The questions that I heard so far from the group have been phenomenal. I just wanted to share that. And I also wanted to ask a question because I actually have a friend that was in a hospital with Crohn's and has been dealing with that for years. I think what ended up happening is I think the parent had passed away, and it's been something that's been in their family for a very long time. And the conversations that we have all the time now talk about how long COVID, with things like fibromyalgia, you're seeing more cases of that now. Like, how is that intersection playing right now with that need that you guys have spoken so much about? And I think Gordon touched upon it in terms of public health. I wear the public health hat too, so I understand that there's so many different implications in terms of social determinants, but more to it, long COVID is still understudied. It's still not fully understood as far as the implications. And I would think that one place that will really, really touch on this is probably somewhere in rheumatology. So could you speak to that a little bit and speak in terms of what is going to be the long-term ramifications with respect to long COVID and how that intersection plays in the future of the field?
I honestly have no idea. And I agree with you that we're probably going to be involved. Like in early COVID, and, you know, on the adult side, we were all deployed to see these patients, right? Because it's still predominantly adults rather than kids that get hospitalized. Kids do get hospitalized, but orders of magnitude more. It's definitely more the adults. You know, where when we saw all of these patients and sort of like the multi-systemic nature, I felt like it was intimidating to a lot of doctors, but like for the rheumatology, because we ran out of doctors. Like, I'm going to tell you, wave 1, we ran out of doctors and they're like, okay, everybody go to the hospital and help. So like even podiatrists were helping. Like podiatrists were like drawing blood and stuff. And they're like, I haven't done this in ages. And like, we ran out of doctors. So everybody on board. And Rheum got deployed to see COVID patients because we have, right, a general medicine training background. But it was crazy because those manifestations of COVID, like it felt very familiar to us. Like I would call my colleagues with what we were seeing on the floors. I'm like, I feel like COVID is the hell baby between vasculitis and antiphospholipid antibody syndrome, which are 2 diseases that we readily treat. And I'm like, do you feel like this is the hell baby of vasculitis and APL? And they're like, oh my God. Yeah. And then sure enough, it's because COVID like causes a whole bunch of clotting, like antiphospholipid antibody syndrome does, causes a whole bunch of what we call like endothelial activation. So a lot of inflammation of the blood vessels. So you can get strokes, you can get PEs, you can get heart attacks, you can get all this stuff. So it's like, this felt very familiar, like just from the jump. And a lot of the medicines that we're using now for severe COVID are immune modulating medicines like tocilizumab, otherwise known as Actemra, where it's the inflammation that the virus sets off is what ends up killing you. And that's what we do all day, right? We manage inflammation, and the inflammation that the immune system sets off that tries to kill our patients, not from a virus, but from, whatever sparked their disease. So I do feel like now that we're in long COVID, and I do think that people are underestimating the mass disabling event that is COVID, that we will probably be involved, because we've seen a lot of patients with now inflammatory arthritis post-COVID that never had inflammatory arthritis before, that have inflammatory eye issues that never had inflammatory eye issues before, that have like their inflammatory disease kicked off probably because of COVID. And whether they were just kind of simmering and then COVID like let the horse out of the barn, or right, COVID just did something to the immune system. I don't really know, but I feel like I agree with you. I think Rheum is going to be involved in that discussion, and probably we're going to see that it's a lot of immune regulation is probably what's causing a lot of the long COVID symptoms.
Thank you for taking my question. Appreciate it.
There's also an aspect of pain, of chronic pain, that is coming along with COVID. And, even in pediatrics, we are also seeing an increase in that. Like, they had COVID a couple of months ago and we're in there having chronic pain. So we are seeing that as well. And really, we would treat them the same way we would treat a fibro/amplified musculoskeletal pain syndrome. And that's what we've been doing. But there may be something else that we discover of a better way of treating them. But for right now, those are the tools that we have, and that's what we're using.
Okay, there are so many good questions in the chat, and unfortunately, I don't know that we'll get to everybody's, but I wanted to pick up on one issue about career choice, since we are talking about moving into residency fellowship. The question was about integrating global health experiences. And I'm curious also, when you talk about the path for rheumatologists, what are the options available to you? Is it mostly academic? Can you go into private practice? What do you see sort of for the future if somebody's considering this as a specialty and they want to know what their life could look like?
So I'm going to start first, because I'm so sorry. I have to jump off at 7, and then I'll leave you in Dr. Akinsete's amazing hands. And she literally just won an award for being like the world's best teacher to our trainees and our medical students. So you're in great hands. There are so many options in rheumatology. Again, you can be more on the ped side, you could be more on the adult side, right? You could be med peds, which you actually do both. You can be academic, and most actually pediatric rheumatologists are academic, and I can let Dr. Akinsete talk about that. But on the adult side, you could be academic, you could be private practice, you could do research, you could not do research, you could do education. Like, you can literally do everything and anything. And I think that that's just by the nature of how rheumatologists think, right? We think in systems, we think in big questions, we think sort of overarching problems when it comes to the patients, and when it comes to sort of how our patients move through the world, right? So I think that, a career in rheumatology really you can make it whatever you want it to be. So for global health, my co-chair of the DEI task force, Dr. Shira Blazer, who's also at the Hospital for Special Surgery and will be Dr. Akinsete's mentor, because rheumatology is that small, by the way. It's really that small. We all know each other. She does amazing global health in looking at potential gene differences between American and West Indian populations in lupus. And so she's actually studying a Ghanaian cohort that she started with her mentors, with her African mentors. And so she's comparing and contrasting American gene profiles in lupus with West African gene profiles, and like, what are the differences and what are the similarities, particularly given that obviously our population of Black patients is derived from West Africa. And so what are like genetics and what could be potentially more environmental, right? Because, you know, through the Middle Passage and everything that people have been exposed to since then, you know, how has that changed our genome and potentially our predisposition to lupus? And so like, yeah, you can do anything in Rheum. You know, you just have to go into it, please. We got to retire at some point. Right, so we need the next generation to come. And with that, I will leave you all. Thank you all so much for coming. And Ms. Hasler and Joe Wiederhorn have my email. So if any of you want to reach out, let me know. Bye.
Thank you so much, Dr. Blanco.
So yeah, like Dr. Blanco said, you can do whatever you want. I've even created this niche of doing health disparities research, and that's what I'm going to end up doing. So you can, in pediatrics, it's a little different. You can't do private practice because there's, like like Dr. Blanco mentioned, it's rare, and it's even rare in pediatric, in the pediatric population, are diseases. So to go out in private practice, like you may see one patient, once a year, it would be difficult financially to maintain yourself in private practice. So you would be in academic medicine, but as she mentioned, you can do education, you could run a program, you can be the director of a program, you can do research. So it's very education, everything, it's wide open. And in rheumatology, like if you're part of academic medicine, like even as a fellow, I have one of my co-fellows is going to be going to Kenya to look at how JDM affects the pediatric patient over there compared to the US population. So there's a lot of opportunity. So they even have associations like PAFLAR, which is particularly looking, it's the African continent. So if you can think of it, you can probably do it. Someone out there, and even if like it's not happening, someone will help you do it. Because the disparities exist in the United States, but also worldwide. Like why there's only one pediatric rheumatologist in Nigeria. That country's huge. And there's probably a lot of pediatric rheumatology conditions that just are going undiagnosed. So there's a lot of opportunity everywhere. And I think it's just a matter of coming in, taking advantage, looking to see what's available, and then finding people who can help you, because we are all weird, but we are all willing to help each other out because we are such a small community that, you can send your paper to someone in Prague and they'll answer back immediately and help you with something. So it's a very collaborative community. So there's not a cutthroat situation here. Everybody's trying to see everyone rise up and really help our patients. So I think it's a wonderful field. If you are interested and want to know more about pediatric rheumatology, I'll put my email in here too. But yeah, I would love that all of you come. And then there was a question about like how you become. You go to med school, you do your residency, whether it's in pediatric, internal medicine, or do med peds. So that's 3 years. And then after that, you do a subspecialty, which is rheumatology. So that's typically how it goes. Oh, let me put it in.
Great. Thank you so much for sharing your contact info. And I'm so sorry that we are run out of time. This was a fantastic conversation. If there are additional questions, I will put my email in the chat as well. You can feel free to reach out to me. If you had any questions for Dr. Blanco, I'm happy to pass them along. And I just want to say thank you again for joining us. Thank you to our presenters, and we look forward to talking to you again soon. Thank you all.
Yes. Thanks for all the interest, guys. Please come. All right. Bye.
Bye.